and give the hypothesis that you're using or the negative differential diagnosis. And I'll send you a PDF of this as well. Okay, so the first case is this one. The patient with posterior elbow pain with swelling and pain on palpation and leaning on the elbow. So don't worry about what the hypothesis is for the moment. How would you generate it? A single hypothesis or negative differential diagnoses? Then having decided that, write down the hypothesis if you've done a single hypothesis or the differential diagnoses you're going to eliminate. Does everybody understand? It's going to be quick. All right. The next one is a patient with lateral elbow pain with pain on elbow movement.
Jim, are these all just different cases and you're just asking us to, or
All different cases. Yeah.
all different cases?
Each a different case. Yeah.
Okay, thank you.
I'm not particularly interested in what you generate, but the reasons for the way you generate hypothesis, okay? And that's what you should be interested in. Lateral elbow pain with pain on gripping. And finally, severe central with both buttocks, the right more than left, both in the back and in the leg, and pain on flexion and extension activities. Are you good with that? Okay, Teresa, did you decide to generate a single H1 or negative differential diagnosis with A?
I decided to go with single hypothesis.
Okay. Abby?
I decided to go with negative differential diagnosis.
Okay, interesting. John?
I did a negative differential diagnosis.
Okay. Chris?
Negative differential diagnosis.
Okay. Cervantes?
Wow.
The negative differential diagnosis as well.
Okay. Michelle?
That was the same.
Okay. Chan?
I did a single hypothesis.
Okay. Ariel?
I did negative differential diagnosis.
Okay. All right, so we can stop there. All right. If you were gonna, all right, let's do this. Who said single hypothesis? I know Teresa did.
Yes, I did.
Okay. Why did you do that? I'm not saying it's wrong. Why did you do that? Actually, you can't be wrong with this question, all right? You cannot be wrong. with whatever answer you use, so don't worry about being wrong. So why did you pick hypothesis, the single hypothesis?
I thought it gave me a good in a direction of a single hypothesis.
Okay. What did you think it was? Or what was your hypothesis, rather?
Olecranon bursitis.
Okay, all right. Now, who picked the negative differential? Pretty much most other people, I think. Chan, I'm looking at your name. I think you picked negative differentials, didn't you?
I did not. I was the
Okay,
other single.
all right. Of course, there's only about two of you, and I picked the wrong one. Michelle,
I picked a negative differential diagnosis. Like my thought went to bursitis and potentially even a fracture because they didn't say if it was
trauma or not?
trauma. So if you just palpate.
No, that's not my question. You said you picked negative differentials and then you went straight to it being a bursitis.
No, well, it could be. My mind went to either bursitis or a fracture, but I feel like you could easily rule those out just by palpating if it's not.
You can, but that then becomes negative differential diagnosis. It does. And that's a perfectly good reason for it because it's easy to rule out things. You can rule out a fracture by asking if they had trauma.
Right.
Yeah? So that's a perfectly good reason for picking negative differentials. Now, in this case, going with a single hypothesis is reasonable, very reasonable, because there isn't much else. If you haven't got trauma, there's not much else that will do that to you. And if I've not mentioned trauma, it's not a traumatic patient. I'm not trying to trick you here, all right? So there's not much else this is going to be. Your real problem comes in, is this an infective bursitis or something else? Okay, so that's where the problem comes, not so much making diagnosis. But what you've got to do here, if you're going with a single hypothesis, even though it's fairly straightforward like this, you must do error correction, errors and bias and error correction. So that you still end up doing differential diagnosis. Either way you do this, but there's very little chance of you getting this wrong because of bias. How many of you have ever seen this case? Has anybody?
I've seen it once or twice,
Okay.
but it was a secondary injury to something else.
Okay, but it's not terribly common because a lot of these things have a huge golf ball size swelling in the back of the elbow and the patient doesn't have any pain. So you really can't look at availability bias because if you've never seen it before, it's not available to you unless you've just done a course on bursitis, olecranon bursitis, then it's available. So availability bias isn't a real problem. So this is a perfectly reasonable one to pick single hypothesis. So now the second one, lateral elbow pain on elbow movement. Same question again.
Jim, can I go back to the first example here? Can I just can I tell you kind of my experience with it?
Yeah.
So I initially wrote down H1 and olecranon bursitis.
Yeah.
That's just kind of my first thought.
Yeah.
And so now I'm thinking, well, that's my own bias because I have experience with that. I go to my negative differential diagnosis of, say, a fracture.
You can do. You can do that. You can basically, it may just be joint swelling, atypical joint swelling. Sorry, mute it, would you? Whoever it is. Okay. No, you can do either. It's not so much availability bias isn't available to you, even if you've never seen one. If you've read about it recently, that would make it available. It's just that this one is fairly straightforward. Okay, it's more likely to be olecranon bursitis than pretty much everything else put together. in the no, I'll leave that alone. It's much likely to be an electron bursitis with all this going on than anything else. So bias isn't a major problem here, but you can do either one. You're going to come back. You have to come up with some differentials anyway for this when you're going to check for bias. And your problem now is how many differentials can you come up with for electron bursitis that is non-traumatic in nature? Can anybody come up with another differential for this presentation? Because I'm struggling.
It's a bit of a stretch, but maybe a joint sepsis or infection.
Yeah, it could be possibly be an atypical arthritis. So, fine. You want to, like, if you're actually, whether you're using differential diagnosis, generate a hypothesis or check the diagnosis, the negative way is a better way. So how would you check for an arthritis, an atypical arthritis of any cause? Eliminate it with a single test.
Just doing some mobility testing, looking for like a capsular pattern of the elbow.
Now, quadrants. Remember what you're doing here. You're trying to eliminate it. So a quadrant and as a pathology. Okay, so you don't have to be fancy about this. Just do the quadrants. If they're negative, move away from the joint.
Jim, I have a quick question about the quadrants.
Yeah.
Are you going to go over them this weekend, or do you have a resource that we could go through? Because I did not learn that in PT school.
No, you'll find them in module 6, cervical spine and shoulder. If you're
Is
looking at
that open
shoulder
to this-
quadrants or elbow
I can give
quadrants
you
should
some
be
videos,
in the 4th module, peripheral elbow.
Yeah, I can
Okay,
give you some
thank you.
videos. I can give you some videos. So is that okay with number one? One of the
Yes.
reasons you don't do negative differentials is you can't think of them. That's probably the best reason for not doing negative differentials is because you can't think of one. Is that okay? Now, second one, we okay to move on? Lateral elbow pain on elbow movement. Kevin, I don't think I've spoken. Have I spoken to you? Anyway, I don't care. Kevin, single H1 or multiple differential, negative differentials?
I'd go negative differentials.
Okay.
That one.
Kristen,
I went negative differential on this one.
okay. Stephanie,
I also went with negative differential.
okay, seems to be a trend. So anybody go single H1? Okay. I would go that as well because it's unusual. It obviously happens. But there are a number of things that can cause lateral elbow pain, isn't there? On elbow movement. It could be the joint. It could be, it could still be the muscle. It may be that the joint is more of a problem than the muscle is. So this is their biggest complaint, elbow movement. It could be muscle, tendon, joint. Could be ligament. So you've got a number of things that could be causing this. So it's actually more efficient to go to negative differential because you pick one of them, your job then, that becomes H1, your job then is to prove it. So you're going to do positive testing to see if it's actually that. Whereas to eliminate is much quicker, much more efficient. Is that the thought that was going through your minds?
Yeah, especially with this one, you didn't give us much information, so it makes more sense to try to eliminate things rather than choose something right off the bat with limited information.
Well, interestingly enough, with that combination of things, what's the most likely source of the pain? There's only two, lateral elbow pain and elbow movement. And I'm telling you what, on the next one, you won't say that because you know what it is. So you should know what this is as well. What's the likely source of this pain on elbow movement?
Probably in the joint.
Yeah, yeah. Because look at the third one, lateral elbow pain with pain on gripping. I can guarantee you that you will all pick a single hypothesis. Is there anybody who didn't pick a single hypothesis? Again, it's not right or wrong. It's a choice. Both choices are equally valid. Some are easy to work with than the other choice in certain cases. That's all. So did anybody pick negative differentials for this one? No, because going in, you're pretty sure of what it is. Yeah, but you're still going to have to do negative differentials when you come out with a diagnosis or the provisional diagnosis when you do your bias and error correction. Because as we talked about, this could easily be the radiohumeral joint causing this. Nowhere near as commonly, but it can do. Is that okay? Severe central and bilateral low back pain with referral into both buttocks, right more than left on flexion and extension activities. So, Violetta, single or negative differential?
Can you hear me?
Yeah.
Okay, sorry, I wasn't working earlier. I said single.
Okay. Why?
Because I feel like my mind, as soon as I started reading it, was going to like a single hypothesis. And then from there, I could kind of try to eliminate bias through different ones.
Okay, yeah, certainly that's a way of doing it. That's an absolute way of doing it. And there's nothing wrong with that, except I think this may end up being a bit messy.
Okay.
I think we'll find out. Did anybody do differentials, negative differentials?
I did negative differential.
Okay, why?
I feel like I would just want to know more about what's going on there. So I put down a few things that it could be.
Okay, all right, then you eliminate them. So my guess is the first thought here, if you're going for a single, and probably at the top of your list of differentials, is a disc herniation. Am I wrong? Anybody think of something else? For their primary differential or for the hypothesis? Okay.
I could be wrong, but what about like a spondylolisthesis? I can't quite remember the essential illness script for that, but that's something that I thought of kind of off the bat. And I can't quite remember if that's right or not, but what about that one?
Yeah, it can be. Yes, it can be. It's if the thing is actually pulling on the neura or dura, then you're going to get flexion pain. Coming back into extension, you have trouble with that, and that's going to be painful as well. Mostly, though, what you're going to see is this isn't range of motion where it's pain on flexion or extension activities. This is function. So its main problem is going to be extension, more specifically, lordotic activities, because that's going to force it forward more. Whereas things like sitting, you're not compressing anything here. If this is a spondylolisthesis, it won't be compressing the disc. So with a spondylolisthesis, you expect to see more pain on prolonged standing and walking. Okay.
That makes sense. Thank you.
So the problem with it being a disc, well, it's not a problem. It could be a disc herniation. It could be, it could actually be a combination of a disc herniation and a spondylolisthesis, which is a real bitch to sort out. Believe me, that is not easy to sort out. And there's a few other things it could be. It could be a disc and a stenosis, but it looks like you may have multiple problems here. So a disc is probably the most likely one that isn't multiple problems. Is that okay? So what I'm doing now is I'm just explaining my thought processes on this. What's your, like, if you're going to positively test this for a disc herniation, how would you go about it? What test?
You could do a straight leg raise test.
Yeah. Yeah. Because you know what you're doing. What are you expecting to see with a straight leg raise test?
Causing pain pretty quickly in the
Yeah.
range of motion.
Yeah. What if you don't get that? You may have a straight leg raise, but it's not terribly limited. Or you may not have a straight leg raise.
With that, based on your videos, Jim, we could still have a disc pathology with a negative straight leg raise.
Yeah, so you're
Just a
thinking of a
different-
contained herniation.
Right.
Yeah.
So it
Yeah,
actually,
exactly.
despite being a very sensitive test, despite it being a very sensitive test, it still doesn't necessarily rule it out. Correct?
Each one.
Lumbar disc.
Contained or uncontained?
Well, that's the difference right there. So it would most likely be positive in an uncontained disc pathology, right?
Yeah.
So contained, then that's more likely we'd see the negative straight leg raise.
Yeah.
So our traditional training would tell us if it's sensitive test, it's negative, rule it out. And then that, now you're saying, well, hey, we could still have this contained disc herniation or disc pathology.
Exactly.
And have a negative straight leg raise.
Yeah, perfect. That's exactly right. It's still a disc herniation. It's just a type that doesn't compress the dura or the neura. So all of the pain is coming from this. That's exactly right. And it's important you sort these two out, because if this is a contained herniation, what's your major concern here with this case?
Jim, I have a quick question. So if
Yeah.
if it's a contained, if it's not pushing on the dura or the neuro, would you even see like this severe pain? So would our biggest concern be like a cauda equina issue?
If this is an uncontained disc herniation, absolutely.
Right. So what would we be seeing with the contained then? Because it's obviously still an issue, but would we have the significant pain with a contained
Yeah.
disc herniation?
Yeah. All of the pain is coming from the disc.
Okay.
And that's the difference. If you're getting this sort of bilateral pain, you really want to be careful about your neurological testing and make sure there isn't any radiculopathies going on, because if there are they on both sides? And is it a radiculopathy or is it a cauda equina pattern? Yeah. So my feeling would be if I had bilateral discogenic, well, not discogenic now, sorry. If I had an uncontained disc herniation that was compressing, that was bilateral, particularly if it was getting worse, I would definitely get hold of the doctor and say, do you think this might turn into a cauda equina? Because I think it might. Do you want to have another look at it? That's exactly what I would do. I've had that exactly happen to me. I had a woman come in, bilateral pain like this, and she was a warehouse dispatcher. And she wouldn't stop working. So she was sitting on a high stool, sort of leaning on it, and every day, and I saw her once, I said, you need to go and have a word with your physician. I said, this is probably going to get worse pretty quickly. She didn't, she carried on working. And then she came in to see me a couple of weeks later, and she said, it is worse, it's down both legs now, and I can barely stand up. Both straight leg grades were severely limited. And she started getting neurological signs and symptoms, and she ended up with a cauda equina lesion. So that's really an emergent problem in the best sense of the term. This is emerging, and it's becoming an emergency. You good with that? That's exactly right. Good. I'm proud of you. All of you. That's good. Any questions on it? Okay, well, I'll give you a rest and I'll start doing a bit of work for you. We're going to be talking about bias and prejudice. Now, I'll give you the PDF of this. And I can't remember. Did you get a video on bias and prejudice yet? Or bias and error correction?
We had one on bias.
Okay, good. Then this is a review of it, and possibly that's going to give you a chance to ask questions about it as well. So, bias and prejudice, they're not the same thing. Bias is a tendency to lean towards, while prejudice is prejudgment, an assumption made on inadequate evidence. Prejudice is always bad because you're going to act on it. Bias, on the other hand, can be good. You can have good bias and you can have bad bias. But all that is a tendency to lean towards a particular thing. All right, so don't be over concerned with bias. But when it comes to diagnosing, good bias will take you to the right answer sometimes. Bad bias will lead you away from the right answer, but you need to check for both, or at least check for bias. Error is a mistake, and we'll go through this in more detail. If you've got any questions, ask me on the way through, all right? Don't wait for me to finish. Okay, so the biases we're really most commonly, there's, if you look in the literature on this, there's something like 50 or 60 different cognitive biases. A lot of them are exactly the same thing with a different name. A lot of them are exactly the same thing with a slight twist. But we'll concentrate on the ones that really affect us. First one is availability bias, which can be regression to the familiar, where you just go back to the most familiar thing you know. This is why you try and fit square pegs into round holes. You're going back to what's familiar to you. But it can also be, and I'm sure you've all done this, you've been on a course about something or the other, and then for the next week or so, all you see are those patients coming into your clinic. This is availability bias. Confirmation bias is where you make your incoming evidence, whether it's subjective or objective, fit your bias or prejudice. Okay, you just make it fit. You confirm your opinion regardless of what the evidence is saying. Now remember, this isn't conscious. Anchoring bias is usually where you get so overwhelmed by the evidence coming in, you grab hold of the first thing that makes sense to you and you hang on to it and you do not let it go. Doesn't matter what else is coming in. This is what I've got. I'm going to keep it. It's mine. That's the answer. Okay. It's generally because you're overwhelmed by the evidence. You're just taking in too much. If you read the lab report or the X-ray report before you do your examination, for example, your diagnosis at the end of this is going to be framed by those reports, and you don't want that. What you want is a completely open mind going in. And this is not good bias when this happens. You know how often X-rays are, you get false positive, false negatives, irrelevant positives. So they're all over. All of these tests preferably should be done after the diagnosis is made, not to make the diagnosis. But in medicine, of course, we've talked about this, they will generate a hypothesis and then prove the hypothesis with the objective test. A good physician will pretty much know what those objective tests are going to show. And if they don't show that, they will say, okay, well, the tests are wrong. Bad clinician doesn't do that. The worst clinician is, we'll order all these tests and see what fits. That's terrible. But a good one will do exactly that, but then be critical of the objective results. Now, this applies to consults. You get a consult. I would suggest strongly you don't read it until after you've made your diagnosis. Don't look at the doctor's script. Just come in blank, all right? Diagnostic moment. I've got the corrections in a minute. I'll talk about the biases, not the correction of them. Diagnostic momentum. This is about keeping the diagnostic process going. You want to get on with it, so you tend to rush through it. Your input is inadequate, or it's more prone towards confirmation bias and so on. But this is about keeping the diagnosis momentum up and making a fast diagnosis. Sometimes it's simply over pressure on working. Sometimes it's just your personality. Probably not do it. Premature closure or search satisfaction is you stopping the assessment too early. You know what it is, but you've stopped too early, and there's information that would have changed your mind. Okay, so they're really the common biases. There's another one, Dan. I can't remember what I wrote. I wrote these this morning. No. Okay, so errors. These are just mistakes. All right, you've made mistakes. The first one is going into the exam with the incorrect information about the condition that you end up diagnosing. It's just wrong. You've been taught it wrong. You misunderstood it when you was taught it. You misread it, and so on. But there's the information you have about the condition that you're going to diagnose is incorrect. Your measurements are incorrect. Misinterpretation of the measurement results. Not listening to the patient. That's a big one. I did a residency once in Dallas, and we had a patient come in, and he was taking the history from the patient, and at the end of it, he said it's a biomechanical dysfunction. So I said, well, what about the positive straight leg raise? He said he didn't have a straight. Actually, it was a tech. No, what was it? Actually, I can't remember. I think there was a straight leg raise up. There was something in the history, and I can't remember. Anyway, I said, what about the straight leg raise, for example? And he said, there was nothing wrong with the straight leg raise. So I said, it was limited to about 60 degrees. No, it wasn't. And the guy went, is that when you lifted my leg up? So I said, when he lifted my leg up, I said, yeah. I said, that hurt a lot. And he just didn't take it in. Or he'd already made up his mind about what the diagnosis was going to be. And this is confirmation bias. Listen to the patient, all right? That's the only thing you have to do with the subjective part is listen to them. You're in too much of a hurry for whatever reason. You'll be distracted by things other than the exam. You're tired. Or you're being overwhelmed by too many distractors in the patient's information. This happens a lot in the emergency room. Patient comes in with multiple injuries and they're complaining about the less serious ones, and the serious one is not being complained of, and that gets ignored. And that's what ends up killing the patient. So if you've got too many distractions in the information, too many sources of pathology, they're talking too much, and you're getting distracted by this, this can lead to problems as well. So we've got a bias and error correct, and the question is, how do we do it? For bias, do differential diagnoses. All right, that will cover nearly all of the biases. And I would suggest negative differential diagnoses for bias and error correction. If you're worried about anchoring, or sorry, not anchoring, but premature closure, complete the exam you started for premature closure. So it doesn't matter what the exam is. I'm not saying do the whole exam. I'm not doing the whole scan exam. But if you started doing script focus hypothetical abduction, finish that process off. Okay, finish the process off. Fill for the incorrect or inadequate knowledge. Fill the knowledge gaps. All right, and the only way you can do that is when you come across them. So when something is happening that you really are not sure about, or you find out that you're wrong, fill that gap in. All right, do it as quick as you can and make sure it's in there. But you've got to fill knowledge gaps. We've all got knowledge gaps, nothing wrong with that. Just make sure you fill them up when you get the opportunity. Do the test correctly and with care. Don't be casual about them. Now you'll see Dave doing these techniques next weekend, and it's going to look very casual to you. Like he's doing them loosely and it's not important. He isn't. He's practiced these enough that he can do it easily with facility, but he's still doing them properly. He's taking note of different things very carefully. Resistance to not just the end field, but the resistance of the end field. Is there hypertonicity? There's a lot of stuff he's picking up, but he looks casual with them. Until you can do them enough with facility, your test should be consciously done with care. Okay. Number 3, I forgot what that is. Look. Misinterpretation of results. So this is difficult to deal with because you, after time, you don't know that you're misinterpreting the results, but at least know what the test is testing and the probability of it giving the correct results. So this can be done through sensitivity and specificity numbers. It can be done through likelihood ratios, diagnostic accuracy, and so on. That could be difficult though, because you need to know the sample that this was done on. Does that sample reflect the population that your patient's in? But you should have some idea of how good the test is in your hands and how likely it is to give you a good result. Okay. Otherwise, this is a difficult one to deal with because a lot of misinterpretation is down to bias. As far as distraction is concerned, hang on, let me make sure I'm talking about the right one again. 4 is not listening. Okay, it can get boring. All right. But there's nothing you can do about that, but overcome the tendency to switch off. You can ask to overcome this. If you find you're getting bored, ask an interesting question that may have nothing to do with their problem. Just understand why you're doing it, and that might wake you up a little bit. All right, but it can get boring, and all you can do is try not to be bored with it. And I'm sure you've all experienced that with some patients, haven't you? 5 is being in too much of a hurry. Now, this may be because there's too many problems to look at. Motor vehicle accidents can do this. If that's the case, break the examination down into components. There is no rule that says you have to examine everything in one go. This is where it can become tiring. Something like motor vehicle accidents, you might want to break that up over a couple of visits, deal with the more important stuff on the first visit, and then deal with the next on the next visit, because it can get overwhelming and it can lead to tiredness. You break the exam down. I used to do it because we had a very limited amount of time with patients. Motor vehicle accidents and complex patients, I give them over 2 or 3 sessions, treating the ones I've done, but not look at everything in one go. Okay, outside distractors, concentrate. All right, don't worry about football stores. They'll still be there when you finish the exams. Everything extraneous, don't worry about it. Your patient is your responsibility. All right, and your professional priority as well. Okay, what's this one? 7, being tired. All right, don't get drunk the night before and stay up late when you've got a work day following on. Just staying up late is going to make you tired the next day. Try to be a bit more disciplined with your time during the work week. All right. I'm certainly not going to lecture you on getting drunk. I can do because I'm pretty good at it, but this isn't what this is about. Don't stay up when you don't have to stay up, basically. If you are going to stay up and you are tired, don't take any real risks with this. Don't make irrevocable decisions, and only do things that are easily corrected and not harmful. All right. So you can give your patient no placebo treatment at all, but you're going to have an idea of what they need to do, and you can do that. It's not going to do any damage, and it may help. Something like putting a hot pack or electrical treatment on them, and not doing anything at all risky. All right. And for number 8, which is being overwhelmed, don't do too many tests and do too many questions. Focus on what you're doing with the diagnosis, and your questions concern that and not anything else. All right. And again, if you've got multiple pathologies, break the exam into components and look at each one individually. So I'm going to ask you for comments on this. Jacob, I know there's a lot there, but what do you think? Is it feasible?
Sorry, dealing with a current clinic problem right now. It wasn't paying attention to the last slide for a second.
Okay. All right. My question is, do you think this is feasible then? Let's have a look. Who haven't I pulled up here? Ryan.
Yeah, I think that all makes sense, and it's all good to keep in mind when making clinical decisions. It seems pretty feasible.
Okay. Anybody disagree? Feel free. These are open discussions.
Just
Yeah.
a comment, Jim, I think the most challenging one would be misinterpretation of results.
Yes. Yeah,
Right?
that really is. Yeah, it really is. Hang on a second. Yeah, it's on the